Mr. Dr. Amit Malik coming in, who will be talking about person-centric healthcare. Dr. Amit Malik is a psychiatrist and a healthcare entrepreneur and is currently the founder and CEO of Amaha, India's largest mental health organization. With over 20 years of experience, Dr. Malik is dedicated to improving mental health care accessibilities both in India and globally. He has completed his undergrad medical training in India and pursued postgraduate and higher training in psychiatry in Nottingham, UK, where he obtained membership in the Royal College of Psychiatrists and the certificate of completion of training in psychiatry. In addition, he holds an MBA from London Business School and a diploma in geriatric medicine from the Royal College of Physicians. He has worked in psychiatry in the UK for about 15 years, treating and overseeing care of thousands of patients with severe mental illnesses. He held several leadership positions within the NHS, including clinical director and associate medical director. He also served as a trustee of the Royal College of Psychiatrists UK and was a board member of the European Board of Psychiatry. As commercial director on the board of an NHS mental health trust with a budget exceeding $200 million, he played a very critical role in building and managing multi-site services. Under Dr. Malik's leadership, Amaha has grown into India's most trusted mental health organization with a strong in-house team of over 200 psychiatrists and psychologists. Dr. Malik is a globally published author, having co-authored and co-edited 6 textbooks and has been published in several international academic journals. He has also served on the editorial boards of International Psychiatric and the International Journal of Social Psychiatry. Let's give a big round of applause for him.
Good afternoon. I definitely need a short introduction. Thank you for having me, Vijay. I don't know how to best talk about this topic that Vijay gave me, and I think the best thing I could do was talk about how we think about mental health care at Amaha and the approach we've taken in the last 10 years to try and deliver more person-centered care, essentially. Right? And so I just thought, I've worked in mental health management for about 20 years now, and one of the reasons I started Amaha was because the way healthcare services are typically set up around the world, and I've worked in a lot of parts of the world, they are usually set up for either the system or the economics or the doctors, right? They're very rarely set up around the client and the family, essentially. And what that does is creates innumerable barriers for access, and that results in families presenting very late for support and treatment, and that has very adverse impacts on outcomes. So that means that the illness lasts longer, it's much harder to treat. The economic, financial, social costs have significantly gone up by the time somebody presents for services. And so we actually sat down a few years ago and said, okay, if we are saying we are different, how are we different? What are the principles that should guide our decision making when it comes to client work, right? And that's what I thought I'd just talk about. We came up, we spent a lot of time as a group of individuals within the organization, just trying to figure out what are those principles? What do we actually believe in? What is our belief that underpins our delivery model, our care model, right? Because the reality is, most places you go to, as long as they are reasonably well educated and trained, will give you similar treatments for a particular condition in mental health, right? But in our belief, the experience is a lot more than just the treatment. And I believe the experience is everything that goes around it, and that defines engagement, that defines whether you stay in treatment or not, that defines your trust in crisis, that defines how much you can lean on somebody when you really need to, right? So those things are broader than just the pills you get or the therapy we talk about. And trust me, I'm a medical doctor. I'm not taking away from those things at all. But I'm saying there is something more than what that really drives good outcome. So what are the things we came up with, right? This is what we describe internally as the Amaha way, right? We say, okay, if we are different, how are we different, and what do we do differently? And this is our way of reimagining healthcare and mental healthcare in this decade, this century at least, right? And I'll take you through each of these, and so we don't need to spend too much time on this crowded slide. But the principle that underpins this conversation is saying, when faced with a tension, when faced with a conflict, when faced with a decision, these are the principles you apply, right? These are. So how should you show up in the world for families and clients you support? And we are a large team. We're about 400 people team now. So how do you support and can you see what happens in healthcare is you cannot run everything by protocol. You build protocols, you define protocols, but there is so much one-to-one care happening for the individual and the family that what in the end carries you through is the principles and cultures you abide by. And so the thought is saying, when faced with a conflict, what are the things that are really important, right? And so we came up with these 6 things. They might be right, they might be wrong. They're just what we came up with. And the first one, the idea of not defining an individual or a family by their condition or diagnosis. Was saying that the diagnosis, the condition is just one part of this person's journey. How do we look beyond that? How do we try and work with the person and the family as a whole rather than just focusing on ये diagnosis है, इसका ये दवाई है, इसके बाद 2 हफ्ते बाद आना, फिर 4 हफ्ते बाद आना. How do we at least try and look beyond that? And by the way, we are still a work in progress. So we're not fully there yet. I'll be the first one to admit that. But that's what we try to solve for. And that becomes so important. We've got this booklet, and you can see it. I sort of showed it to you later. This is a booklet that basically codifies what we're talking about, and we try and hand it out to all the people who work with us and say talk about the voice and the way we want to operate, essentially, right? And this, at a very basic level, is about talking about the biopsychosocial approach, right? But that's the starting point. That's not the end of the conversation. It then is about your story, the pace at which you show up, the pace at which the context in which you are operating, your reality. I think all those things have to play into this. And that is why it's very important to be very careful about the kind of clinicians you work with, the kind of systems you operate, and the kind of spaces you build. And I'll talk a bit more about the spaces at the end of this. I think that's very important to say that you're starting with a person, not a diagnosis, right? And that's principle one, right? I think the second thing which we should be able to take for granted, but unfortunately we can't, is, are we showing up with the right science, the right evidence base, the right systems? Are we actually doing what has the best chance of recovery and success for a particular family and individual, right? And that it means applying and responding with depth, responding as a team, right? Because mental health is a team sport. It's not an individual sport, basically, right? And really being disciplined about execution. And again, as you scale up, as you're now working with 250 odd clinicians, this is more and more important because it's much easier to do this when you are an individual practitioner in a clinic. How do you make the promise about saying, no matter where you show up in our 10 plus centers or online or in the hospital, your experience will underpin a lot of expertise, evidence based science, because that has to be a given. Unfortunately, it's not always a given at least in our ecosystem, basically, right? Empathy is critical for all mental health professionals to develop, and it's such a hard skill. And I've spent years teaching medical students on empathy, and my clinical background is in geriatric psychiatry, and it's so hard as a 31, 32-year-old psychiatrist to really imagine the ecosystem of somebody who's in the late 70s developing memory difficulties or dementia, and it's so hard to live with that. So, how do you actually try and sit in the shoes of the person in the family who's struggling? And if you can't, at least try to. At least try and do the thought experiments of saying, okay, what would this be like for them? What would this be like for them at home, at work, in their relationship, during meals? What does it feel like for them? Is what empathy means. And I think that is a very, very important point that I think helps build connections so deeply. And if you miss that, what you end up being in is a very transactional relationship, right? My family psychiatrist in the room. She's been dealing with not just my dad but also my mother in parallel, showing a lot of empathy and understanding for her situation as a caregiver, while treating my father at the same time, right? So I think the idea of being able to really connect with that reality by trying to put yourself in those shoes, as hard and impossible as that might seem, is a very, very important aspect of building the service. And I think the good thing about empathy is you can train to develop it, right? That's the good part. The challenge is an intent to have empathy, right? And then to really develop it, not just fake it, right? Because clients and families are very, very sharp. They will know in a minute when you're faking it, basically, right? So actually really, really trying to understand what that means. The fourth is really about trust. And when you're younger, you believe if I say something, if I promise something, that is what trust means. But as you get to my level of gray hair, you realize that trust is really about showing up consistently. Trust is about showing up in crisis. Trust is really about following through on your word and your promises. And that trust takes a long, long time to develop. Right? You can start with the principles of what you want to do, but expecting a family that has gone through struggles sometimes for months, sometimes for years, sometimes for decades, and expecting them to have that trust on day one is a tall ask. Right? They will do that because they're desperate and they have to. Right? But actually, to truly develop two-way trust takes what it takes is consistency in showing up, right? Not failing people in a crisis, following through on your word. Those things are what help develop trust. And trust is so important because when things are really going downhill, when there is a relapse, when there is a crisis, the reason a good clinician can act as a facilitator is because they've developed trust over a period of time. And if you don't do that, then you've lost a key tool in your arsenal or your armory to be able to really be able to support the family at that point of time. I was told by a very, very old professor of mine when I started in mental health, God, many, many years ago, not 25, 26 years ago, that the biggest tool you bring to a consultation, an interaction, an engagement is not your clinical skills, it's not your science, it's actually the ability to instill hope in a family that might have lost all of it, essentially. And so I think the idea of being able to do pattern recognition, where you can actually tell somebody that I've seen this like this before, and that builds, and then it has gotten better. The idea that you can point out the progress that clients might not see themselves, the idea that you can remind families when they've forgotten to even expect change and improvement, right? Because things have been so difficult for so long. That idea of hope is a critical tool. And I think of all the things we do, hope is probably the most critical thing in terms of actually driving recovery, maintaining relapse prevention. Because if you don't have the hope as a clinical team or a clinical professional, then why is somebody coming to you? Why do they need to spend their time, energy, money, trust, all of that with you if you can't instill hope in the fact that there will be recovery at the end of it? And that hope is not just again in words, it's by pattern recognition, it's by both in them and based on your wider experience. It's really by pointing out progress. It's really by reminding people that things were better at a point and things can get better again. And the last thing, which is something you learn with experience and sometimes the hard way, is that your job is not to have somebody keep coming back to you. Your job is to have somebody never have to come back to you. That is the job. Right? The job is to say, can I get somebody well enough? Or can I work with them to get them to get well enough? And which means about restoring their choice, their confidence, their ability to navigate their daily life, their relationships, their work, all the things that are important to them, where they can get the best control they can possibly get for the condition they're living with, essentially. Right? Now, I don't sit here and talk about full recovery. That's sometimes possible, sometimes not possible. But can you be a facilitator? And I think that's the best word to use for somebody on the journey to get to the best version of themselves that their condition allows. That's the big part of the role, essentially. I think I'll just stop there for a second and just recap that, right? So the idea really is to say, keeping the individual and the family at the center, how do you bring deep expertise to the table with an empathy-led approach? So your expertise with empathy to build trust, instill hope, and then empower people towards independence, right? That's what we're trying to do. We fail almost every day. We see around 600 to 700 clients in a day. We fail on a daily basis at some point or another because it's hard. It's not, and those of you who work in this space, experience this space as caregivers or people lived experience, you know it's hard. But that's the aspirational goal we work towards on a daily basis. How do we apply this, right? I'm just going to take 5 more minutes and talk about how do we apply this. We've just, the first thing is we do a lot of training around it, right? I mean, this is and you can see this, I'll ask Saurabh to show this around, but this is a handbook we like to leave with all our clinicians. It talks about the thing we just talked about in more detail. It gives more examples of saying, how can you show up in certain situations in a certain way. So this is a handbook we just try to work with them. And that's one part of this distributing this thought process that's emanated from a small core, but then now it needs to apply to the rest of the organization. We do a bunch of training. We do a bunch of training with clinicians on the ground. This is the training happening in our new hospital in Bangalore. We do a bunch of training with the individuals who are not clinicians, but actually the first port of call when you call us up, you reach out to us, either for the first time or even during your care journey, basically. Right? So that's the, and you really have to keep going back to those principles. Right? The training is more about saying, okay, how to apply the principles, but you really have to keep going back to the principles, and you need to do it on a regular basis because as the team changes, the team expands, people forget, day jobs are difficult. I think it's easy to gravitate towards something that is more instinctive and comfortable, and some of this is not. Some of this is saying, this is not about me, this is about the person sitting across from me, this is about them and their family and their journey, and I'm just living with the privilege of having to facilitate it or getting to facilitate it. That reminder is not always easy. So how do you then go back to it? It's about repeated conversations. I would be the first to admit, we still don't do them as often as we would like to, right? But I think the more you have these conversations, especially because a lot of the people we work, especially in this team, the care team, are very, very young, right? They're very young, well-intentioned. A lot of them are psych graduates, and so just actually being able to instill those principles, going back and revisiting them when there is actually a challenging situation, when things have not worked out, that's when you can really drive some deep, meaningful change, basically. I think the last bit I'll just take 2 to 3 minutes to talk about is saying, this is the new hospital in Bangalore, right? And we then had to translate some of these principles into how we design the hospital. We said, okay, we've got these principles, they've been around for a while for us, we've been working through them. Now we're building a hospital for the first time. We've got clinics for a while, building a hospital for the first time. How do we leverage our thought process, our principles, and create some ground rules for building a hospital, right? So we came up with 5 things. We said safety is important. And that is about expertise, that's about empathy, that is about hope, but safety is important. And because we also understand a lot of times when people come to us, especially at the hospital, they are probably the lowest, riskiest points in their journey with mental illness. And so, how do you create a safe space that's safe? That picture is interesting. We've spent about 6 months designing that open space railing. It's a railing on a terrace. Uh, it's meant to allow as much light as possible, as much open vision as possible. but it's also meant to be safe and secure. So you can't climb on it, you can't do a ligature on it. But we couldn't copy a design from the West because most Western hospitals don't have a terrace that allows for this. We literally had to create this. This took us the longest thing to do in the hospitals. I put in the picture. It's really about safety, but also with accessibility. Right? The idea that the space should not feel closed, cramped, inaccessible. You should not feel like you're in a prison, right? How do you build warm, welcoming spaces where interactions with the clinical team, with each other are more intuitive? You reduce strain on the user because or the client so that you're not struggling on a day-to-day to just be there and get through the day. And the accessibility becomes very, very important. How do you make the place sustainable at multiple levels, right? The material you use, the space, the way you create spaces, the usability over the long term, but also how does it feel to a person, right? The fourth is what is their sensory experience of the colors, the materials, lights, everything else, and the fifth really is saying the aesthetic, right? So the idea is say, can you create warm? That's the actual photograph of the living space, the between the rooms in the hospital, right? Can you actually create a warm space that is safe, is accessible, but is still therapeutic? And so we try to take the basic principles that we have in Amaha way. We've tried to apply them here. We're still a work in progress. 10 years down the line, this is our first hospital. We're building a second one now, and there's a lot of learning. The team sent me a 4-page document of things that are not right with the first one. So now we're working through that to say, okay. And we took input from clients, we took input from the nursing staff, the doctors, the managerial staff, and said, okay, this is a space to build. The first time we built it intuitively. We didn't like anything we saw in the country. So we went back and said, can we apply first principles? Can we apply what we've seen across the globe and build something with the Amaha way principles? We've done that, and we've only got a 70% right. So hopefully the second one will be 85%, and by the time we build the 10th one, we'll probably get 95% right, basically. So that's the broad way we are looking at the mental health space and how we're building in the space in this decade. Happy to answer any questions, right, either now or if you want to reach out separately. But thank you for having me here. Thank you for the time.
May I call upon Dr. Vani Kullali to please do the honors? Yeah. And thank you so much, Amit. Let me mention this here. It just takes a casual chat and a conversation for us eliciting support from Amit, Neha, and Amaha, Team Amaha. That is how much they are committed to delivering these kind of experiences in collaboration with us. We really appreciate it.